Good day, everyone, and welcome to the third and final webinar in this Inherited Arrhythmia educational series presented by Ambry Genetics and the SADS Foundation, entitled Cardiovascular Genetic Testing Practices Around the World. Today, we are delighted to have three world-renowned experts in the clinical and molecular diagnosis of inherited arrhythmia conditions, Dr. Michael Ackerman, Dr. Silvia Priori, and Dr. Robert Hamilton. The speakers will each give us an overview of their genetic testing approach when diagnosing a patient with an inherited arrhythmia, as well as provide a comparison and discussion of how the diagnostic process differs in each country due to external influences, such as care guidelines, privacy requirements, and third-party payer systems. So without further ado, I'd like to introduce our first speaker and host for today. Dr. Mike Ackerman is the Winland Smith Rice Cardiovascular Genomics Research Professor and Professor of Medicine, Pediatrics, and Pharmacology at the Mayo Clinic in Rochester, Minnesota. He has published over 400 articles and chapters across the continuum of basic, translational, and clinical research, focusing on the cardiac channelopathies, hypertrophic cardiomyopathy, and sudden cardiac death in the young. Dr. Ackerman received his MD and PhD from Mayo Medical School and Mayo Graduate School and completed his residency and fellowship training in pediatrics and pediatric cardiology in Mayo Clinic's Graduate School of Medicine. Dr. Ackerman is currently the president of the Sudden Arrhythmia Death Syndromes Foundation. So, Dr. Ackerman, when you're ready, the floor is yours.
Great. Thanks a lot, Benjamin, and welcome everybody out there to this third webinar. And on behalf of the SADS Foundation and with the privilege of serving as its president, I really want to thank the support of Ambry Genetics for this. This is a education around genetic cardiology in general and genetic testing for the heritable channelopathies and cardiomyopathies is critical. The need to increase the genetics IQ of the users of genetic tests has never been more necessary, and I'm delighted to moderate today. The layout for today is Dr. Silvia Priori is going to get things started with her comments from her experience. You see her bio. She is incredible in many ways. She is one of my dear friends in this field, and I think it's fair to say that we have the privilege of listening to somebody who I refer to as the queen of the cardiac channelopathies. And so we'll have her start, and then after she's finished, we'll have about a 15-minute monologue from a good friend of mine and a veteran in this field, Dr. Robert Hamilton from Toronto SickKids. He will then have his comments, and then hopefully we'll have at least 20 to 30 minutes for us to enter into a dialogue with you all as you register your questions. So as you're thinking of a question, please enter them. I will sort of note them, and we will then move into hopefully a very interactive and exciting question and comment session for the balance of our hour. So let me move this over now to Dr. Silvia Priori. She's in Italy at the moment, so it is about 7 p.m. there. She's going to give us the European perspective, but I think she's fully capable of giving the perspective throughout the entire globe. So Silvia, and shown are Dr. Priori's disclosures, and we'll let her continue on. So thanks a lot, everyone, and I'll be back after she's finished.
Welcome to this conference on webinar. We will be discussing the management of patients with inherited arrhythmias, taking the interesting perspective of the differences from various countries. And in particular, this kind of topic is important because it makes us thinking of the importance of the environmental influence on how we practice our medicine. So first of all, who manages patients with inherited arrhythmias in Europe? These patients in Europe are identified by different kinds of physicians. In several countries in Europe, we have screening systems that are part of our preventive medicine program. In some countries, it is an electrocardiographic checkup at neonatal age in the first days after birth. In other countries, like in Italy, is a strong screening of athletes of any age. So children may be screened when they engage in sport and have electrocardiogram taken. This brings in the picture pediatricians, cardiologists, sports physicians as doctors that identify patients with these conditions. And these patients are usually identified, spot suspected by different physicians, but then the majority of them tend to send the cases to referral centers. The system organized with referral centers in Europe is facilitated by the fact that there is a public healthcare system that actually provides reimbursement whenever the patient goes in the country. So we have no restrictions like, whether the insurance will cover someone from southern Italy to come to northern Italy to a referral center or vice versa. And the same system is in place in the majority of the other European countries. Furthermore, the advantage of having access to referral national centers is guaranteed by the fact that we could easily apply guidelines in the management of patients because the decision is in the hands of the few physicians at the referral center. So if guidelines can be understood and applied by the physicians working at the referral centers, how actually it works that we can keep a consistency in the management across Europe? I think that in this respect, the European Society of Cardiology has had a very important role, not only in inherited diseases, but overall in trying to be an important element that facilitates uniform approach for physicians across Europe. And there is an agreement between the European Society of Cardiology, ESC, that the national societies, Italy, France, Spain, Poland, will not develop their own national guidelines, but they will actually accept and translate in the national language the European guidelines. There are still an element of diversity by other societies, like, for example, in our field, genetics or sports medicine, that may produce independent documents, and this could create a different perspective that healthily contributes to the fact that the majority of the cardiologists will adopt the guidance provided by the ESC. So this is an example, for example, of the 2015 guidelines for the management of patients with ventricular arrhythmias and for the prevention of sudden cardiac death. This document is the latest document produced by the European Society of Cardiology and has been accordingly translated in the several different languages. There are 50 countries that belong to the ESC. Let's take, for example, an issue like family history that in the guidelines is, of course, considered a very important component of the management of patients with inherited channelopathies. Sometimes in certain countries, and especially in the large countries that will be discussed after my presentation, Canada and US, there is a challenge in getting detailed family history, because of many factors that are social factors, but they eventually influence medical practice. Limited mobility, small size of the countries in Europe provide a major advantage to reach out to family members, collect family history, and collect genetic samples. This, in principle, facilitates the application of genetics to large groups of patients within the same family. Similarly, when we talk about the clinical evaluation, is the same. The important factor here that facilitates in the European system the ability to comply with the recommendations, that is, collect an extensive clinical evaluation, is related to the fact that the healthcare systems that is public provides coverage for the cost of all the different investigations. So when the guidelines recommend a new test, it can be more easily implemented in the system because everything is reimbursed in the same level for all the people throughout each of the countries. So in the 2015 guidelines for the prevention of sudden cardiac death, for example, we have seen a several number of changes as compared to previous vision in the management of the different diseases. And thanks to the fact that now the translation of these guidelines has allowed the possibility to provide all the countries with the translation of this documentation, we have been able to adopt in a broader way the recommendations. So here is an example of the diagnosis of long QT syndrome that is showing the recommendations for the diagnosis in these patients. My slides are jumping. I don't know what is happening. So I hope that the audience is seeing right now the slide that shows the long QT syndrome. And here we can see that there are recommendations of class 1 for the patients that directed to the recording of the electrocardiogram. What has been introduced new in this setting is the fact that we have a cutoff of 480. Previously was a cutoff of 500 in previous guidelines, and the ability of having this recommendation rapidly translated has profoundly facilitated the adoption throughout Europe of these new criteria. When we look at the next disease, that is the short QT syndrome, what we are showing here is the fact that we may have criteria, again, of class 1 and class 2 that can rapidly be made uniform, and especially the cutoff that is less of 340 currently for the diagnosis of short QT syndrome. In the next slide, what we are seeing is the diagnosis of Brugada syndrome. What is shown here is the fact that now there is a recommendation for adopting recording in the highest leads as a criteria for complete diagnosis. So recording of the diagnostic right precordial leads in not only in the fourth but only in the third and second intercostal space has become now a European recommendation that is being adopted in most of the countries, as seen in the next slide that clearly spells out this recommendation. Interestingly, as we will hear in the other talks, this recommendation was initially proposed by the joint guidelines produced by the Heart Rhythm Society in a conjunction with other heart rhythm associations, including the European one. But we believe that thanks to the global translation of the guidelines produced by the European Society, we are able really to reach a larger number of individuals. Finally, to conclude, in the diagnosis of catecholaminergic polymorphic VT, in the recent European Society of Cardiology diagnosis, we have been able to send a very strong message that also the patients that carry a pathogenic mutations, even without showing a phenotype, should be considered as affected individuals. And this once more link the importance of an appropriate diagnostic criteria that includes, whenever needed, and when we are certain of the meaning of the mutation, the introduction of genetics in the area of the medical decision. The next slide we will be discussing, similarly, how the environment can influence therapy. So the challenge to a consistent management among European countries is now no longer in the hands of the willing of the physicians, but on another challenge that comes to the system worldwide, and of course therefore also in Europe, that is related to the variable availability of certain drugs that are very critical for the management of patients with inherited arrhythmias, but may no longer be available on the market for decisions of companies that have withdrawn the drugs from the marketing of drugs being generic but not properly available in the different countries. So drugs like nadolol, that is pivotal for the management of patients with CPVT and long QT syndrome, mexiletine, that is pivotal for the management of patients with long QT3 syndrome to shorten the QT, are facing a strong shortage in selected countries. The other point that we need to keep in mind as a challenge to a uniform management strategy in Europe is the fact that we have differential economies. Some are more advanced and some have more difficulties in adopting the most expensive therapy. And now let's go to the issue of genetic testing, who performs genetic testing in Europe, and how the healthcare systems influence actually the adoption of genetic testing, the penetrance and the availability in the different countries. Of course, being from Italy, I like to start from my own country. We are organized in a way that public healthcare system covers the cost of genetic screening for all the patients in which a cardiologist or a clinical geneticist finds the need for the request of genetic testing. As you see in the dots here, all the laboratories that can freely provide genetic testing in Italy have to be laboratory accredited with the national healthcare system. So we have no private suppliers of genetic testing for free. We have private suppliers that do it on the private sector of the market that is quite small. Italy is part of the country that adopts the Lisbon Treaty. That is the treaty that prevents discrimination and therefore prevents the legal use of genetic results to deny insurance or to deny rights to patients with genetic diseases. In the next slide, we will see the situation of Spain that is in a way similar to Italy, as all the patients get the coverage of the cost from the public healthcare system. But as you see in Spain, there are private laboratories that can be part of the system of reimbursement from the national healthcare. And the EU treaty from prevention of discrimination is also adopted by Spain. Finally, we go to a different model, quite different in the UK, where the health insurance is covering the cost of genetic testing. But as you see in the big one single dot, there are very few centers that are authorized to perform genetic testing for the national healthcare system. So in the United Kingdom, they have this system where there are referral centers also for genetics. Interestingly, United Kingdom is not aligned with the EU Lisbon Treaty for prevention of discrimination, but they have their own voluntary moratorium that has been agreed between the government and the insurance industry. But anyhow, the system is present to prevent this also in the UK. Finally, we move to the diagnostic approach that is used in the exploitation of the information provided by gene testing and genetic screening. We are moving in an area where the pivotal document that I had the pleasure to co-chair with our leader, Dr. Mike Ackerman, was published in 2011 and is still updated to provide guidance. This document has been very well received in Europe and has inspired national documents that fit the specific aspect of reimbursement in different countries. On the next slide, we see the overall diagnostic approach. So the patients may have a diagnosis that is firmly confirmed at clinical level. In this patient, there is a strong indication for genetic testing. In the patients in which the diagnosis is possible but not definitely confirmed, there is genetic testing that may be considered. This approach is particularly relevant when we talk about the family members, in which if the diagnosis is not confirmed, there is really no need to apply the screening of a mutation that is not certainly associated with the phenotype for genetic testing of the family members. And finally, this is another important slide that comes to this document that we had provided with the group led by Mike Ackerman and the Arrhythmia Associations, where it becomes clear that the value of genetic testing is different. In long QT syndrome, we use genetic testing also to guide not only the diagnosis, but also the prognosis and the selection of therapy. This is not true in Brugada syndrome and in short QT syndrome, and in CPVT only to some extent we can apply the presence of mutations for prognostic indications, but definitely not as well as for long QT syndrome. So when managing long QT syndrome patients, we want to be very careful to exploit the real value, the strong value of genetic testing, and this in Europe has been well received by the scientific societies, the national societies that are enforcing the adoption of this criteria. Finally, which gene should be screened is a big issue. In Europe, we have a privilege for the screening of the most common genes and then have a cascade approach and move to the more rare genes only in a second phase. The other question is, how is genetic screening performed? Which techniques are used? So since there are laboratories accredited with the national healthcare system, some of them have been slower to adopt and switch to next generation sequencing and have been using Sanger methods for longer than what has happened in the private sector. Right now, we are moving, most of the labs are moving to a total transition to NGS, but with panels of different sizes, with some countries preferring to use the key gene first and the screening to the other genes in a second phase, thus trying to optimize the use of resources. And finally, how are results of genetic screening interpreted? This is an important difference. In some countries, the results should be provided only by a genetic counselor. In other countries, the cardiologists are allowed to provide the results to the clinicians and to the patients. Importantly, there are differences in the interpretations where in countries like the UK, where there are few centers that provide genetic testing, it's easier to move towards a uniform system. So the cascade screening is the one that has been preferred in Europe. The result of genetic testing, though, is interpreted with the same approach used worldwide, where genetic testing leads to a classification that has approximately 4 categories, where a mutation with a certain pathogenetic implication is the strongest result. The negative, so no pathogenic variant identified, is the last, but still strong because allows to exclude the presence of a known genetic disease in the family that may still have long QT, but we cannot define of which type. And the complexity, of course, is the category of the variants of unknown significance. Trying to conclude, I think that there are major differences in how the genetic testing and management of these patients is practiced in the different countries that are mainly related but what is available through the national healthcare system and the structural organization. At the level of science and medicine, the national societies are harmonized with the European Society of Cardiology that often is inspired and includes also members in their guidelines development that come from other countries. So the scientific community is pretty aligned, I would say, worldwide. Thank you very much for your attention.
Well, Dr. Priori, thank you very much. And we're going to now turn our attention to Dr. Robert Hamilton and his presentation. And again, after his is completed, we'll enter into some questions and try to answer them to the best of our ability. So if you're thinking of any or have any, go ahead and post them now, and I'll start reviewing them during the course of Dr. Hamilton's presentation. So, Robert, I turn it over to you. Thank you very much.
Thanks, Mike. So welcome to the Canadian section of today's webinar. So Canada has some unique challenges. Our land area is equivalent to the United States, but we only have 1/9 of the population. In contrast, Europe is 1/3 the land area of either the US or Canada, and the population density is often much higher. So for instance, Belgium's population density is 354 people per kilometer squared, whereas the U.S. is 1/10 of that at 33, and Canada is 1/10 of that at 2. So we have a lot of area to cover to look after a rather spread out group of people. However, in 2014, we only spent about 10.4%, just above the world average, of our modest gross domestic product on healthcare, covering 100% of our population, perhaps compared to 17% of GDP in the United States. And our current and enduring model of healthcare, Canadian Medicare, was proposed by a social democrat named Tommy Douglas. And you can kind of think of him as the Bernie Sanders of his time, if you've been following American election politics. And he implemented province-by-province Medicare between 1962 and 1964. Now, I'll just digress for a moment. I had the pleasure of going up to the cottage for the last long weekend, this weekend, and on the way up I drove, because the main highway was busy, through two small communities that were home to two rather famous Canadian physicians. One is Sir William Osler, and one of his quotes, the bottom one there, is, "Medicine is a science of uncertainty and an art of probability." And I think that was rather prescient, and I think nowhere is that more true than of cardiac genetics. The other community I drove through was Gravenhurst, which was the birthplace of Norman Bethune, and he's best known for bringing modern medicine to rural China during one of the very early wars. He treated sick villagers as much as wounded soldiers, and his quotes are there, but I would suggest that there's an element in terms of genetic testing that he, as perhaps one of the more socialist physicians of his time, said that we were selling bread at the price of jewels, and this may be true as well. And I think you'll see that point made as we take a look at how genetic testing in Canada has evolved. So where are we at? This is the other scene that I passed on the way up to the cottage. There's the hay bale in front, which I think of as the physician and the family trying to find the needle in the haystack, looking for the cause of their inherited arrhythmia condition. But in the background are the silos that consist of the geneticists that are not necessarily talking to the cardiologists, and the genetic laboratories that don't necessarily talk to each other, and certainly government and insurance agencies that don't speak to any of them. And so if we all operate in silos, as we have in the past, I think you'll see that the ability to move ahead with genetic testing in our country was impeded, but eventually overcome through some communication. So what are the principles of the Canada Health Act? They are universality, comprehensiveness, accessibility, public administration, and portability. So for universality, all Canadian residents must be covered, 100% for basic medical care. And for comprehensiveness, all medically necessary physicians and hospital services must be covered. The problem is this is administered province by province across the country. And so each province can decide to what extent cardiac genetics are considered medically necessary. My comments will talk mostly about my home province of Ontario, where I think we've been fairly advanced in our uptake and translation of cardiac genetics. These are the kinds of costs across the country to provide all health care to individuals, and they range from about $5,000 to $6,000 per individual per year. So you can see that, to add in a cost for a single genetic test of, $5,400 US would add quite a lot to any one individual's cost of health care in each of these provinces. And you can see that, unfortunately, because of the universality of health care insurance being administered by government, by the provinces, that this actually takes up a large portion of each province's budget. And so in tough times like the recession that we just came out of, there's always a move to try to reduce health care funding and thus, unfortunately, health care services. So it's in this background, and particularly during the recession of 2007 to 2010, with the evolution of increased genetic testing that was becoming available, both in terms of research findings and in translation to clinical genetic testing, that I give this talk today. So in 1995, long QT genes were discovered, and I was looking after patients here. I had been for 6 years and was fascinated by the identification of long QT genes to explain the phenotypes in my patients. And so we started banking patients then. And initially, we would send a sample to one of the research laboratories, and it would sit on a shelf, and we would never hear back. So we started storing the samples here and then just sending a portion of the samples. The first clinical long QT gene test came available in approximately 2003, and we devised a system to basically take advantage of clinical testing for long QT syndrome. For right ventricular cardiomyopathy, which was becoming an increasing problem, an increasingly identified problem, there was only a single gene initially provided by Johns Hopkins as a clinical test, and we felt that we wanted to try to expand that, and so we actually participated in the development and translation of research genetic testing in ARVC over to clinical testing. And so a SickKids ARVC test panel was developed and listed on gene tests. And then with the advent of the recession and the exponentially increasing cost of cardiac genetic testing, as well as other genetic testing in Canada, the government, particularly the Ontario government, started taking a look at repatriation of testing from out-of-country testing. All of these tests had been sent primarily to the U.S. and sometimes to European laboratories, and started trying to set up to do them in-house in laboratories in Ontario. And this really took two phases, the first one beginning around 2011, and the second one beginning around 2013 to 14, which we're in now. So what the Ontario government recognized was that there were approximately 2,300 gene tests at the time in May of 2011 when they reviewed this, and yet less than 120 gene tests were being performed in Ontario, most going to the United States, and with exponential increasing costs, primarily due to volume. And they recognized that our out-of-country testing costs would be greater than for all genetic tests now performed in Ontario at the time, and that was in May of 2011. So they felt that something needed to be done. Now, we certainly contributed to that increasing exponential use of genetic testing, and so our routine at the hospital for sick children here became quite streamlined. We would basically select a gene test by the cardiac specialist and the genetic counselor working together. All we really needed to do in Ontario to get funding for the test was to send in a short application if the test was performed out of country, which it always was at that time, along with, at the time, a letter, and we developed a template-based letter to request gene testing out of country. And in addition, many of the companies requested a company consent from the patient. And because we're also a research center, we also like to get research consent. So we would approach the patient with all three of these consents: the consent to apply for funding, the test company-specific consent, and the research consent, and do all of that concurrently, and then immediately send the patient downstairs to have a sample drawn and extracted and banked. And if there was research consent, we'd actually get two samples and split them at the time. Now, we'd wait 2 months to get our approval, and then the sample would get shipped out of country, and then we'd wait another 2 months to get our result, and so within about 4 months we would get our result. We had a contract with province-wide laboratory companies, so the patients didn't have to come here. They could go to their local community, and there were about 100 laboratories spread throughout the province. This ended up in a large biobank, and we maintain that biobank with over 1,000 samples for long QT syndrome and over 1,000 samples for right ventricular cardiomyopathy. And this is the simple form that had to be filled out. It has some patient info, some referring physician info, some recommended lab info, and some payment info. But again, the government recognized that this was becoming increasingly costly to the government, although one could argue that the costs in the long run are compensated by the improvement in care. And so they decided to try to repatriate gene testing They recognized they had 8 molecular genetic labs, 11 cytogenetic labs, and 4 metabolic genetic labs. And they were all funded by the province, yet less than 15% of the tests that were being performed in the province. And so they decided to repatriate 5 tests, one being genomic microarray for congenital anomalies or developmental delay, but the other 4 being all cardiac tests, right ventricular cardiomyopathy, dilated cardiomyopathy, hypertrophic cardiomyopathy, and long QT syndrome. And they wanted to increase the capacity, maintain the quality, but reduce the cost of out-of-country testing. They got an expert panel together with no cardiologists, despite trying to repatriate 4 cardiac tests, but made up of cytogeneticists, molecular geneticists, and clinical geneticists. And they provided a report to the ministry, who then selected laboratories to move ahead with all of this. At the same time, the cardiologists, very similar to Silvia's presentation, were identifying how we should be using genetic testing in the clinical evaluation of inherited arrhythmia conditions. But as you can see, this was primarily cardiologists with the assistance of our cardiac genetic counselors, but no clinical geneticists on the panel. So again, we have these 2 silos not really talking to each other. And at the same time, we were trying to translate our ARVC research testing over to clinical testing through an NIH program called CETT, which provides clear approval and listing on genetests.org. We had 5 genes and good research results, but there was no provincial remuneration to our clinical laboratory. For us, only our out-of-province country testing that were coming into us were being paid. So this was the initiation of repatriation. At this time, the ministry provided a contract, but provided it to elsewhere, not to our lab. And for ARVC, they only applied it to 3 genes and 1 specific mutation of a 4th gene. So very incomplete testing at the time for this first level of repatriation. The more recent repatriation, which occurred in 2013 to 14, now provides for very good in-province panels for all of the inherited arrhythmia conditions. And it's actually not very often now in the last year or 2 that we need to send samples out of country. So other things happened in terms of access to testing. For a while, the province suggested that only medical geneticists should be able to send off genetic tests, but we managed to turn that around by working with our genetic counselors involved in cardiac care, and this was quickly reversed. Another problem that we had was that related to decedent testing, and so the government, in terms of trying to reduce costs, began refusing health insurance. They had the right to do so because health insurance does die with the resident, but for many years they had overlooked this issue in terms of helping us try to provide answers for families and for cascade screening of related individuals. But with budget issues in 2010, again, the bureaucrats withdrew this process and enforced the rules. So we moved over to the Ministry of Justice, which looks after the post-mortem evaluations and autopsies of patients, and they began sending genetic tests instead. So the money was still being paid, but it was just being paid out of a different silo. Now the Ministry of Health has agreed that they may send genetic tests on decedents upon request and with approval. The other thing in Canada is that there are currently no patient protection for genetic tests. There is no Genetic Information Non-Discrimination Act in Canada. However, there is a universal free health care coverage, and there are no direct employer contributions. So for the most part, the issues around that brought in GINA in the United States really don't apply in Canada. However, there are still life and travel insurance issues. And currently, we're still the only G7 country that doesn't protect genetic test information. But this should change shortly with the passage of a bill in front of Parliament at present. So the remaining problems, there are still some administrative silos that are measuring cost but not benefit of genetic testing. The real problems are the limited proportion of individuals or families with identified genetic causes for many conditions. probably only about 1/3 of patients with ARVC can have an identifiable gene, similar for Brugada Syndrome and other of these conditions. And then finally, as Silvia suggested, there's this problem of what to do with variants of uncertain significance. So I would suggest, as a last slide, that there are some potential solutions. One possibility would be for better phenotypic data to be provided with the sample. One could discount genetic testing if research consent and phenotypic information was provided. This discount could be offset by research grant payments for genotypic data with phenotypic data, very similar to what Medicare in the United States currently requires for ICD registry data. And this would provide disease-specific biobanks and sequence data to assess the generalizability of novel disease gene discoveries. And it might also provide the opportunity to identify even family relationships anonymously through techniques such as estimation of recent shared ancestry. So that's my presentation of gene testing in Canada. There are still challenges in cardiac genetic testing related to working in silos, profit versus budget motives, and particularly around the interpretation of results. But these may well be overcome through communication and collaboration. Thanks very much.
Thanks a lot, Dr. Hamilton. And that our time is now open for your questions for the three of us to try to address. Obviously, time doesn't permit me to comment on the superiority of the American way. Just kidding. But there are some key differences. You heard the approaches and the issues in Canada. You heard the various approaches in Europe of the one system United Kingdom way versus the multiple public routes for genetic testing and the hybrid public and private. And those who are in attendance, the participants, the 70 or so listed, many of you may be from the United States, and you know that our issue is very different, where we can have any physician of any rank, of any specialty, order any genetic test that he or she would like, with or without the assistance of our genetic counselor colleagues, choosing to tap into any of a number of private fee-for-service genetic test companies in the space of cardiac genetic testing. We probably have no less than a dozen companies, including one of the sponsors of today's webinar, Ambry, for us to choose to utilize. As we're all aware, and I think both Dr. Priori and Hamilton mentioned, the adjudication of the variant is really become of critical importance, and this really isn't a new issue. For example, Silvia, Priori, and I warned of this now many, many years ago, that variant adjudication and deciphering between the pathogenic mutation versus an innocuous variant, albeit rare, and perhaps albeit really rare, was going to be the key. And we now realize that the quality of variant interpretation is variable throughout the world and heterogeneous at best. And so we have significant challenges, whether we're talking about the United States or the land mass north of us or across the pond. So those are just some overarching comments of the American system. And we have one question posted. Please post others and start sending them in. But the first one that's sent our way states that many family members have been clinically diagnosed with long QT syndrome by cardiac tests. All the gene tests have been negative. 3 of the family members have also had seizures. The individual states that her genome has been run twice, and that a well-known long QT aficionado, Dr. Michael Vincent, felt that this family's long QT type would be eventually discovered. Are there any new testing methods on the horizon? And I think this question is a really important one. It emphasizes or showcases the value that Dr. Priori talked about of having that family be part of a referral center that specializes in these diseases, so that when and if we get a genetic test back that's negative, first of all, the cardiologist should never be surprised by a negative genetic test. It'll be negative in 20% of our long QT patients. It'll be negative in over half of the ARVC patients that Dr. Hamilton was talking about, and that when we encounter a family who clearly has the disease, but whose genetic test is negative, that they can be routed to a research effort to try to discover that family's root cause. And there are indeed new testing methods on the horizon. If you're in Europe, you should be reaching out to Dr. Priori to try to find the cause. If this person is from the United States, we would be happy to partner with you. And it starts with obtaining a phenotype, figuring out who exactly in the pedigree has this disease, and if many individuals do, taking advantage of the power of comparative genomics to take those individuals through a genomic sleuthing exercise, whether it's the entire genome or a subset called the whole exome, and see if those phenotype positive individuals share anything of interest together, and then trying to build a case for that family's disease causative mechanism. And with this strategy in place, many of the minor genes for these various diseases have been discovered. And so that family who really has the disease should not give up, should partner with a center of excellence who wants to find their cause to take advantage of the latest genetic strategies. We don't have another question yet, so I'll ask my colleagues, Drs. Priori and Hamilton, maybe start with you, Sil, if you have anything that you would add for this question.
Yeah, maybe I ask a question to you because both Canada and Europe have a social system and you have an insurance system. It seems to me from the time I've practiced in the US that the insurance system may provide challenges in terms of not having a uniform approach to what is reimbursed to what is not. How do you see this moving along for the future?
Yeah, I think that's kind of the question when it comes to reimbursement in the United States. I think, the landscape is clearly different. When I started accessing a commercial clinically available genetic test in 2004, and that was the year that Dr. Hamilton cited as really the advent of clinically available diagnostic genetic testing as opposed to research lab-based testing, I probably had over 75% of my patients where we tried to secure the test get at least 75% of the test denied. So I had a majority of time complete denials, and now I would say in the kind of patients who come with their insurance to a place called Mayo Clinic, we have over 75% of those same kind of patients getting over 75% of the tests covered. So among the same clientele, if you will, there's been a significant uptake in genetic test reimbursement in a view among all of the different insurance providers, whether it's Blue Cross Blue Shield or WellPoint or Aetna or really any of the major private insurers, of an increased recognition that there is value in the genetic test for these kind of genetic heart conditions, that they are not simply investigational tests. So we've seen a changing landscape, but I think one of the threats to it that's emerged is, and Robert pointed this out in Canada, the insurers would rather not pay for things, and including the countries, they would rather not pay for things if they could get away with not paying for them. And the insurers have started to put out the line, which has been proved to us that there's an outcome difference based upon the genetic test result. So they're, Silvia, they're kind of putting a line in the sand that is unachievable for the next 20 to 50 years to clearly prove that by virtue of the genetic test result alone made a survival outcome difference. And, you know, if they insist on that, I think that's going to be a real threat, and potentially we could see the progress of reimbursement that's been achieved over this past decade set backwards.
Yeah, you're right. So, you know, actually how we practice, you're saying, you know, can influence the position that the regulatories, or in this case, insurance, are taking. This is a very good point, and incentive to practice wisely and follow guidelines.
In your case, Mike, the problem is that the benefit may be for another family member who's insured by a different agent.
Exactly. And the benefit, as you know, it's really hard to measure the near-miss collisions that might have occurred without that. You know, so the individual who got the simple counseling of what drugs never to get, you never know whether that piece of information had a transformative, life-saving impact, you know, because we can't do a parallel cloning exercise. And so it's really hard to measure, you know, the avoidance of near tragedies. Well, another question has come through, and I think we can generalize it. It's specific to Mayo Clinic. The individual is asking, how do you find out if my decedent's son's blood was tested at the Mayo Clinic? It was submitted in 2003. And I think this, first of all, even though it's been 13 years since the passing, sympathies about that tragedy. I mean, I think the three of us are well acquainted with the incredible tragedies and the family stories that we have the privilege of engaging in. But I think maybe the way we can generalize the question is, what do research laboratories like Drs. Priori and Hamilton in mind we do? Because we have two different roles. We are clinicians who have the privilege of taking care of families. We also have research investigations. And Dr. Hamilton pointed out how sometimes samples he would send to a research lab and nothing would come back. And I think research subjects, no matter who they are and where they are, always have the right to engage that research laboratory for follow-up, a status report. Most research laboratories do not inform the research subjects that nothing has been discovered. Usually the point of contact for the research laboratory is when something has been found that crosses the threshold of duty to inform, duty to warn. And so, you know, but that doesn't prevent a research subject to call out of curiosity or interest to say, just checking in, have any advances, any insights been made with our family's sample? That's how we would approach that. We would welcome that call, as long as that there's an understanding that as soon as a sample heads to a research laboratory, there actually needs to be a research subject expectation that perhaps nothing will ever be found.
Yeah, in this respect, we are not allowed to send samples collected in the clinics to research labs. Even we have to separate in our own hospital the research lab that may use DNA for scientific project, discovery of new genes, SNPs analysis, from the laboratory, so the part of the lab that is actually working for the national healthcare system, exactly for the reasons and the concern you are outlining. So I think that the patients need to be aware when the sample is going to a clinical facility and when it's going to a research, and the two processes should be kept separate and clear for the patient where their sample is, and clear the expectation of the difference of the two systems.
Good point. There's a great question here for the three of us. Is there a significantly higher proportion of patients who are opting for out-of-pocket payment of genetic tests so that the results are not in the reach of insurance companies, or in the case of Canada or other countries, not in the reach of the country bureaucrats themselves? I'll take the American. I don't think we know that. I think we've seen an increased landscape of insurance reimbursement. So most families that I take care of do run it through their insurance company to see what will be covered and what would be their residual out-of-pocket burden, if any. They're not as concerned with the insurance company having access to it because we did pass the Non-Discrimination Act, the Genetic Non-Discrimination Act into law several years ago, which prevented that insurance company from using that information to alter their insurance coverage. However, not included in that is life insurance. So I would say the minority of my patients choose to pay it solely out of pocket with the goal that therefore the insurance company doesn't see the result. Robert, are you seeing any change in Canada where some individuals are saying, you know, we want to pay for this and we want the result to be in a black folder so that Canada doesn't see my genetic test result?
Yeah, for the most part, no. What we tend to run into is our families who will choose to delay their testing, go out and secure their life insurance, and then once their life insurance is secure, come back for their testing.
How about you, Dr. Priori?
I don't think that we see a lot of requests of confidentiality and concern, probably because the patient feels reassured by the fact that the insurance is not insurance for health that is so challenging for the Italian citizen because of the healthcare system. So they are more concerned on discrimination in schools, in practicing sports activities, a topic that you know very well, that maybe the kids, because they have been screened or found with a variant of unknown significance, may be excluded from sports in school. But I wouldn't say that is a major concern, that the fear that the genetic testing becomes known and leads to major consequences.
Yes, well, we've reached the top of the hour, which is timely because my computer, for whatever reason, just went completely black. So we could potentially take one additional question, but I can't see it. So maybe our WebEx moderator, who's done a great job today, is there a question that you could read for us? And the three of us will take one additional question before we say goodbye for now.
I do see one question here. How far away are we from testing hair or DNA from Paraffy sample from a deceased 10 years ago? My son, SCD, I and daughter, clinical LQTS, can't find gene even on extended panel.
Yeah, so I think, Dr. Hamilton talked about the issues with coverage for doing a molecular autopsy, but this brings about an important issue, which is our difficulty to even start a genetic investigation of a tragic sudden death case with improper procurement of sample that's not DNA friendly. And so rather than trying to get better at extracting analyzable DNA out of paraffin-embedded tissue, I think all of us have been working on trying to have the various medical examiners, forensic pathologists, coroner systems throughout the world obtain tissue at the time of the sudden death investigation that will be DNA friendly. And so working with them to procure a blood sample or blood on a filter paper card or freeze a piece of tissue that would lend itself to a molecular postmortem genetic test. Having said that, there have been some breakthroughs where the various process of next generation sequencing platform, which fragments the DNA, can be taken advantage of with the paraffinization process. So although we would rather not start with a source of paraffin-embedded tissue, we and others have been getting reasonable DNA of decent quality to start that investigation. So we used to say, sorry, we can't even work with it. now we say we'll accept that paraffin sample and do our best to see if we can get decent DNA extracted. Robert or Silvia, any final comments on the aspects or some things about postmortem genetic testing?
Yeah, I think that it's maybe interesting to clarify the fact that the families very often request the screening from hair that they take from the deceased as a sample for memory. And the point there is that those hairs do not contain the bulb, obviously. They cut with the scissor, and therefore it's impossible to use them for genetic testing. And this disappoints very often the families that they have that hope that the hair can be used. And I agree with you that the paraffin samples are tough to use, and there is also the concern of some not reliable results obtained, false mutations and so on. So yes, they may be used, but I think it's always quite challenging the relying on the results.
Yeah, in Canada, two cardiac genetic colleagues have worked with the Ontario coroner system to, for the last 10 years or so, to anytime there's a sudden death under the age of, I think it's 50 with no coronary cause found, that samples are retained, samples of DNA-bearing tissue, typically blood, are retained, and they also have a protocol to examine the heart under a very specific protocol, looking for all of the different cardiomyopathies. So they retain that tissue for about 5 years. I think they've now shortened it to 2 to 3 years, unfortunately, and sometimes we miss samples because of that. We've offered to continue to bank those samples if the families request and the coroner is going to release the sample or discard the sample.
Well, great. Well, we passed the top of the hour, and I want to thank Dr. Hamilton and Dr. Priori for taking the last 90 minutes out of their schedule for this, and our 70-some participants for your past hour. I hope you found it valuable. I want to thank Ambry for their support of the SADS Foundation. As those here know, the SADS Foundation is the largest nonprofit advocacy organization devoted to families at risk of sudden death from one of these channelopathies that we've been discussing today. And our mission at the SADS Foundation is to help families live and thrive despite the diagnosis. So if you don't know us at the SADS Foundation, I would encourage you to get to know us and join us. And if you are interested in more information, reach out to us at the SADS Foundation at www.stopsads.org. So have a wonderful day, and I want to thank the organizers at WebEx for helping us put on a hopefully what will be viewed as an outstanding seminar. So have a great day and take care, everyone.